Thank you, everyone, for joining Dr. Wilt and all of our attendees. Um, we are going to have Dr. Wilt speak tonight, who is one of our spine surgeons here at Rothman Orthopaedics. He sees patients in our Egg Harbor Township office as well as our Manahawkin office. So just a little bit of housekeeping before we get started. If you look on the bottom of your screen, a little bar will pop up and you'll see a box that says Q&A. If you have any questions during Dr. Wilt's presentation, you can go ahead and write your question in there and we will review them at the end. I do ask that you keep the questions kind of general, nothing specific to your case. If you need a more specific answer, please feel free. You should all have my email and my phone number, but I'll also put it in the box. You can send me a message and I can help you get an appointment with Dr. Wilt so we can take a closer look at your own health care. And let me pull it up. We're going to do just a quick bio and then we'll get started. So this is Dr. Zachary Wilt. He's a fellowship trained orthopedic spine surgeon. He completed his orthopedic surgical residency at Rothman Orthopaedics and followed with a prestigious fellowship in combined neurosurgical and orthopedic complex spine surgery at the Cleveland Clinic in Ohio, where he served as the chief fellow. He's originally from Lancaster, Pennsylvania, and he attended Franklin and Marshall College, receiving a BA in chemistry. As I said, Dr. Wilt sees patients in our Jersey Shore offices, which are in Egg Harbor Township and Manahawkin. And now I will let you get started.
Yeah, it sounds great. Thanks for the introduction.
Mhm.
So today, I figured it'd be good to talk about cervical spine disease in general, and then most importantly, like when is surgery the right decision? And that's why I'm here to help. Kristen was nice enough; she kind of went through everything for me. But from Lancaster originally, med school at Jefferson, residency at Rothman, and then I did a combined orthopedic and neurosurgery fellowship at Cleveland Clinic, offices in Egg Harbor, Manahawkin. So I think whenever you have a talk about surgery and a problem with the human anatomy, it's always helpful to kind of go over briefly like the anatomy of someone's cervical spine and things that can go wrong and things that can cause pain, because that's obviously what we're most interested in. So when you look, this is a front view of the neck on the left side of your screen. And in the middle is kind of looking at it from the undersurface. And then this view on the right is from the side view. And you can see that their nerves come out each level of the spine, and that can cause pain. And then on the upward view, you can see how the spinal cord is in the middle, and then that can cause ambulatory function or problems with your function if that gets compressed. And then in between each vertebrae segment is the disc, which can cause problems. This red line, the red structure is the artery that feeds the brain that runs through the neck. So all this is useful. We'll kind of go through it as time progresses in this talk, but it's important to keep this in mind. Even if having a general understanding of it is very useful for the rest of the talk. So we'll talk about three clinical scenarios. The first one will be axial neck pain. So I consider that kind of your bread and butter neck pain that you develop with time and with different activities and arthritis. And then the next one we'll talk about is cervical radiculopathy. So that's arm pain from a pinched nerve in the neck. And then the last one I'll talk about is cervical myelopathy, which is compression of the spinal cord, which is more of a function problem than a pain, although it can cause pain. And then between all of these, there's a lot of overlap. You can have one thing and then the other as well. Just because there's three doesn't mean you can only have one. So what is cervical spondylosis? You'll see it a lot in your radiology reports. And in the radiology reports, you'll see a lot of words that say spondylosis. And if you look it up, you'll notice that that really just means arthritis. Needed a nice fancy word for that. But you also call it degenerative cervical disease. So as people age, it can get degenerative cervical disease, which can lead to arthritis in the neck. And then you can see there by the numbers, what percentage of people have these changes. Well, once someone gets over the age of 65, almost everybody has them. And then, evidence of significant degenerative changes compared to men and women. And in one study that I found, it was 70% of women at 65, 95% of men at 60. And then the majority of these cases tend to present with problems, some around 40 to 60 years old, and then they can progress. More common in men. So this is a good X-ray demonstrating cervical spondylosis or the arthritis, the natural degenerative process that can lead to these problems. You get age-related chronic disc degeneration, and you get these bone spur formation is really common. So if you look in the front of the neck, you'll see that the bone spurs right here start to poke out. And then that also happens by poking out into the nerve and the spinal cord. And you get these things like osteophyte formations and irritation of the joints and the ligament in the neck, which can press on the nerves and spinal cord. So where is it most common? Well, it's most common at C5-6, then 6-7, and then 4-5. And that can lead to nerve pain in certain locations. And so you can see that each one of these levels, each one of the corresponding nerve can get irritated. And that's how when you come into the office and talk to me, it's very important that you get evaluated to see which nerve is the problem because, as you can tell, 65% of people 85% of people over 65 have these degenerative changes. And so it's really important to see whether or not they're causing a problem because sometimes just because they're there, it doesn't necessarily means that anything has to be done. So, here's a good graphics about like what causes the compression. So this is an up-down view of the neck. So that's the spinal cord right here with the nerves as they go and travel down the arm. That's the disc. And when the disc ruptures, it can push on this edge of the spinal cord and the nerve, and that can lead to pain down the arms. It can lead to balance problems. Now, this is the lumbar spine, but this graphic was great because I felt like it really showed the nerves well. So you can see that when you get the arthritis, you get these bone spurs, and then the bone spurs can pinch and irritate the nerve as time goes on. And I included this because there's a lot of nerves that demonstrate degenerative changes and a lot of nerves that go and signal to your body that you're having pain. And so, it's a very complex process, but at the end of the day, it's really nerve compression is the key. So why does it happen? Well, particularly it's due to aging, but as, people with certain types of lifestyle and activities tend to have a higher rate of degenerative changes. And then of course there's always a component of genetic changes to this type of thing. So I like this graphic as well because it showed that, we're on our phones a lot now. And the more you lean forward and you look at your phone, the more stress is on your neck. So you can see that if you're flexing your neck 60 degrees, your head actually puts 60 pounds of strain on your neck. So, as time and time progresses, I think that we're going to be seeing even more of this because we're on our phones so much anymore. Can't do anything anymore without them. So this is a busy slide, but it really kind of breaks down what is cervical radiculopathy or what is nerve pain down the arm. Well, it's most common in the sixth or seventh nerve root, so you can see where that tends to go. So C6 comes all the way down the arm, down to the side of the arm. And so people that have shooting arm pain in that nerve distribution, I immediately kind of have a sense as to what's going on and why they're having that pain. And then C7 tends to go down the back of the arm and then on the inside of the arm as well. And, it's often related to the inflamed or irritated nerve root. And there's a fancy slide telling you about all the biochemical things that happen in your body that causes the pain. But basically, you get these compounds that signal to your body that they're in pain because of the nerve compression, and that's the response. It's your brain signal for that. So you get neck pain, arm pain. Sometimes it can radiate over the scapula. You get some sensory deficits, meaning you get some numbness and tingling with paresthesias. You also notice that if you come into the office, I'll do some reflexes and test your strength because if it's weak in that same nerve in the same area where that pain is, it kind of tells me that that's the problem. And you kind of have a sense of that even without even looking at an MRI. So, when was it first described? Well, it was described a long time ago. So back in the day, they used to only be able to tell what nerve it was based on the exam and the strength that someone had. And so that's important that whoever you see, that they do a good job examining you and evaluating you. Like I said, it tends to occur in episodes. Now, most people that get cervical radiculopathy, it will often go away on its own with just time. And so we do a lot of things that can help that, like injections, therapy, different medications, and then just kind of wait and see with certain scenarios where obviously it can be more concerning. But in regular pain that shoots down the arm, I'll often tell people just take a pause. We'll give you some medications, maybe an injection, and then some time. And then obviously, if it doesn't get better, then we can talk about next steps. So, everybody always reads on their radiology reports, they'll say cervical disc herniations. Well, A disc herniation is a common cause of that shooting arm pain. And so, it happens in 3.5 people out of 1,000 in any given year. Again, like I said, peak incidence is in the sixth decade. There's some risk factors, but at the end of the day, it doesn't really matter if you hit one of the risk factors. It matters if you have it. So if you have these symptoms, it's quite severe. And, if you have a good doctor, they'll look at your MRI, they'll see the disc herniations. It can correlate with the symptoms that you have. And if you have those symptoms, then it tells you that that might be a problem. So I like this because this is a great graphic talking about how the exam is really important. So, if you look at somebody's spine at report on their MRI, you'll see multiple levels of problems, but they really only have one nerve that's an issue. And in that scenario, I really only treat that one nerve. And so again, you can see reflexes, sensation, etc. But the key really is the location of the nerve pain that goes down the arm. So disc herniations and surgery. So they found that, the vast majority of these will go away without surgery, meaning with time it tends to get better. So like 75% of the time it can get better. But those remaining 26% where you have debilitating weakness or debilitating pain, that's a scenario where surgery is really, really useful. So I tend to find that anterior cervical discectomy and fusion to be the most successful because it addresses that nerve compression directly. You can take the pressure directly off the nerve by removing the disc, and you can also then replace it with either a spacer that's bone graft or metal. And then sometimes we also, if you're a candidate for it with some pretty strict indications, a disc replacement is also reasonable. And I kind of view this as like a disc herniation in the back. You kind of take out the disc herniation and you take care of the problem. So, surgery tends to be considered when people have persistent pain that's been ongoing after, a couple of months of treatment and plus or minus functional deficit, meaning if you have significant weakness like wrist drop or weakness in your hands holding things, like sometimes that might indicate that surgery sooner is better so it doesn't become permanent. So this is just a good view of what this looks like. So this left graphic is slices from the side, and then this is slices top to bottom. So you can see where that disc herniation is squeezing the side of the spinal cord and then pushing against the nerve, and that can cause nerve pain, weakness, and balance problems. The last one I'll touch upon is cervical myelopathy. So this is more of a functional problem than it is a pain problem. So we talked a lot about arthritis in the neck. We talked about pinching of the nerves leading to pain down the arm. But cervical myelopathy is where there's compression of the spinal cord. And so, this is the most common cause of non-traumatic quadriparesis or basically progressive quadriparesis over time. It doesn't happen overnight, and that's what I mean by insidious onset. It happens slowly. So this can happen over many years. So the predominant one is people notice gait abnormalities that are progressive, meaning over time you might notice that at one point you had a lot of you were able to do your normal walking, but now you might need to hold on to things more frequently. And the other one that I find is a pretty useful one is myelopathy hand or loss of dexterity in the hand. So you'll notice that the hand muscles can start to decrease. You might have inability to grasp and release your hands, or you might notice that you're very clumsy with your hands, like dropping things, difficulty with balance, difficulty with buttons or jewelry. And then the other stuff is just stuff that I look for, like exam findings. And then in really, really, really bad scenarios, you can have like bowel or bladder dysfunction. So the last thing I put on here is that, people that are predisposed to it have what's called congenital spinal stenosis. So if you see it on your radiology report, you may be predisposed to this, but people have a small diameter of the canal, which means that if you have a disc herniation, it's more prone to pushing on the spinal cord, or if the arthritis gets worse, the spinal cord gets to get pinched. So this is what it looks like. This disc herniation on the left is squeezing the spinal cord, but it's usually multiple levels. And then as the disc starts to degenerate, it can start damaging the spinal cord, leading to neck pain, stiffness, but predominantly this gait instability and clumsiness with the hands. And then at the end stage, it can become paralysis. But again, that takes a long time. So the most important thing that you can do if you have some of these problems or you're concerned about is see someone that knows what they're doing. So someone will give you a really, really good evaluation, review your report, examine you, allow you to put together all of this into pieces that allow you to understand what's going on with you. So I always start with an X-ray. So the X-ray can really kind of give you an idea about where there's a problem. So like this person, you can kind of see that this one disc is wearing out. It's a little flat. It's got the bone spur here as well as in the back. It's starting to collapse. It's starting to show that it's becoming a problem. On MRI, you could see that the discs can start to push against the spinal cord and can lead to some whiteness in the spinal cord that's damaged. And this one shows you how it's being squeezed. And then obviously it's like a thorough evaluation is really, really important. So someone that gets a good history, evaluates you, puts all the pieces together to try to make sure that you figure out what's wrong. A lot of less than 30% of people really present with that neck or arm pain, particularly with the myelopathic cases. Okay. We talked about that. This is a good graphic of one of the reflexes that I like to use. So if you tap somebody's finger, their hands will jerk, and that gives you a sense that maybe their spinal cord is being pinched. That's called a Hoffman. So then you talk about when is surgery the right choice? Okay. So there's different types of surgery, and I'll go through each one of them so we can kind of explain to you what it is, talk to you when it's used, etc. But I think the biggest thing I'd like you to tell you is that surgery works really well for nerve compression or spinal cord compression, meaning shooting arm pain, balance disturbance, hand dexterity problems. What it's not that great at is fixing neck pain. And that's because neck pain can come from that spondylosis or the degenerative changes. And so degenerative changes are really hard to fix. So you can imagine that if you fix one disc in the neck, it's very hard to say whether this disc was the problem or if it was any one of these other ones, or if it's the joints or it's the muscles or it's the posture. And so that's why, you'll find a lot of surgeons that are a bit hesitant to say that neck surgery is a good idea for neck pain. For arm pain or balance problems, it's one of the best treatments for it, but for neck pain itself, it can be challenging. So when do I use an anterior cervical discectomy infusion? Well, I really, really like this in terms of radiculopathy or pain that shoots down the arm, or one level of spinal cord compression leading to spinal cord compression at that one spot. Okay. So I tend to fuse that one or two levels, sometimes three, and it helps in those scenarios where it's kind of isolated to those one or a couple levels of problem. It's my preferred way of treating things in the neck if I can, because it's a faster recovery, not quite as painful. Cervical disc replacement is really, really popular in terms of the literature. So like if you log on to Instagram or TikTok, you'll find people that talk all about disc replacement and they'll all say it's the best thing that's ever happened. Now, I'll tell you that I do like disc replacement, but I think it's a very specific scenario. And this is definitely not the right talk to go on the specifics of when is cervical disc replacement right. But you have to understand that not everybody is a candidate for it, and not every single time is it perfect. Okay. And one of the other things I like to mention when it comes to disc replacement is it's on the newer side. So we don't have really long-term data about what to expect when it comes to disc replacement. So what is it going to be in 20 years from now? So that's why I included this graphic up here. So you never want to try something new when it's very, very early because you never know about the problems. I think disc replacement is somewhere in the middle, meaning it works really well and I think it has good long-term data, but we don't have the really long-term data at the end to say whether it's perfect for everybody. So that's something that it's important that you find someone that walks you through that and whether you'd be a candidate for it or not. Then we talk about posterior cervical decompression and fusion. So this is a really good scenario for people that may have swallowing problems or older patients that have multiple levels of problems. So if like 4 or 5 levels of their neck are being compressed, I tend to treat it this way because it's the best way of taking the pressure off of multiple levels. It's also good for trauma and lots of tumors and things like that, but obviously it's specific to the person. And posterior means you come through the back of the neck. Okay. And fusion means you put some bone graft and then the rods and screws back there. A surgery I do very frequently is called a cervical laminoplasty. This is contrast to a posterior cervical fusion because it's motion sparing, meaning when I do this surgery, there's still motion preserved in the neck because I make a little cut in the vertebrae on both sides and I put this little tiny plate on there that opens up the canal and gives the spinal cord space, but it doesn't fuse it. So, whenever somebody is able to get this surgery, I tend to prefer it. But obviously, there's some indications for this that make it a little bit more strict. This is what the laminoplasty looks like. So you can see the spinal cord is free, and then you have these little plates that are holding it open. This is contrasting fusion with laminoplasty. So these are the little plates in the laminoplasty. And then this is an anterior fusion, and then a posterior fusion behind it. So again, at the end of the day, there's a lot of tools and a lot of things that we can do to help you with whatever the problem may be in your cervical spine. But it's really important that you find someone that knows all of these treatments and can help guide you in this process of recovery. Because at the end of the day, the vast majority of the stuff you don't have to live with forever, but it's important that you get appropriate treatment that's appropriately aggressive, meaning you don't jump to surgery immediately, but when it's time, you have someone that can do it well. So thank you guys. I left the number up here, but then just some of the travels I've done with my wife.
That was
So thank you.
great. Thank you so much. Where's my video? There we go. Thank you so much, Dr. Wilt. Let's see
Of
what
course.
questions we have. Um, is there an age ceiling for surgery? Like, is there an age where you think, I think you're a little bit too old?
No, I don't think that there's ever really an age limit, meaning like if somebody has a problem, in most circumstances, surgery is not out of the question, but you just have to understand that there's more risk as people age. So when you start to get older, your heart and lung may not function as they would before, and it can make the surgery a little bit more risky.
Are there data regarding which cervical disc levels are better candidates for disc replacement? And when would you recommend it versus advising against it?
Yeah. So there's no recommendations for the specific level. Okay, but I tend to find it really useful for young people that have a disc herniation and they have a maintained alignment in their neck because it allows you to maintain that motion. So if somebody has a lot of arthritis, it makes it a little bit more tricky for the implant to be seated properly, and I think it can lead to some problems. So my predominant indication is someone with normal alignment with a disc herniation in their neck that has a, pretty preserved disc height.
Okay. Is EMG a useful tool to help diagnose?
Yeah, EMGs can be useful, although you have to understand that they're not the perfect test. Meaning, if somebody comes into my office with a very clear nerve pain and a distribution, and their EMG is negative, it doesn't necessarily mean that's the problem. And it also, if it's positive, it also doesn't necessarily mean it's the problem. It's not the best test, but when it lines up with all of the other stuff, it makes it very clear that that's the problem.
Can you have a consult with somebody if you've already had an MRI?
Yeah, certainly. Anytime.
Yeah. What type of other methods can be used early on, I guess before surgeries, such as PT meditation, yoga, medications as a first level of relief?
Yeah, I think those are all like excellent things. So I think that if you are working on strengthening your back and core as well as your posture, I think it really kind of protects your neck. So I think yoga and all of those things are really, really good. It maintains motion. I do think that the majority of it is genetics. So I don't think that there's any supplements or anything like that that have been proven to make a significant difference in terms of degenerative changes in the cervical spine. But I do think that maintaining a strong core, neck range of motion, being active, that can all help diminish it. There are things that are associated with degenerative changes like horseback riding, but again, like if that's something that somebody really likes, you don't want to stop that.
Yeah, you got to still have things that
You,
keep you
you
happy,
gotta you
right?
gotta have the things that bring you happiness.
Um, when you talk about degenerative changes, do you only deal with neck problems or do you do degenerative changes in the lower lumbar as well?
I do degenerative changes throughout the cervical, thoracic, and lumbar spine.
Are the areas you mentioned today the only areas? Oh, we just answered that question. Same question. Let's see if there's anything else. There's a question here, and I hit the wrong button. It's asking if there's neck specialists at Rothman in Pennsylvania as opposed to New Jersey. Yes, if you visit our website at rothmanortho.com, you will see all the offices that we have, as well as all of the physicians and specialists we have. How long after surgery will numbness and pain in my arm go away?
Oh, it's a great question. It's very challenging to say. So I tend to think that the longer someone has the symptoms of the nerve compression, the longer it's going to take to recover. But it can take up to a whole year, and there are certain circumstances where you do take all the pressure off of the nerves, but there can be some chronic nerve damage. If that's the case, there's always other things that we can do to help with that. But that's why I think that timely care is important. So you don't necessarily end up in that scenario.
I've had cervical radiculopathy for years and pain for years. I put off surgery by getting Botox injections to reduce the pain. I'm now 65. Is it a mistake to put off this surgery?
Well, I think it's one of those scenarios that, like, when it comes to pain, when it's just pain itself, pain is a quality of life problem. So you have to have a real look at yourself and say whether it's pain that you're willing to live with or whether it's something that you want to address. So if it is bad enough that it impacts your quality of life on a day-to-day basis and the injections and things like that aren't helping it anymore, then surgery is a pretty viable option in a lot of circumstances.
Can lumbar or buttock pain be related to the cervical spine, or is it always related to lumbar spine?
Sometimes it can be. Usually that's in the case of myelopathy, but the vast majority of cases, radiating leg pain is from the lumbar spine. So I tend to look at the lumbar spine first. Well, I examine people really well and make sure that I don't see anything on exam that makes me concerned for the neck. And then if it does seem like it's the back, then and it aligns with the MRI of the lumbar spine, then most of the time that's what it is.
What do you think of a procedure that kills the nerves in the neck?
Yeah, so the pain doctors do the ablations, like the nerve ablations. Those are good scenarios for neck pain. And so that's one of the things I was talking about where surgery works well for nerve-related arm pain, balance problems, etc., and maybe not the best for neck pain. And so I do think that the pain doctors do a good job with the ablations for neck pain in certain circumstances.
Great. Well, I think that was the last question. That was so awesome. Thank you did a really wonderful job explaining complex things. So thank you so much.
Yeah, of course, try to make it brief, get to the point, and answer
Oh
a
wait,
lot of
oh,
questions.
we got one more question. This will be the
Yeah.
last one. What if you have neck pain and radiopathy? Can you work on both?
Yeah, absolutely. Certain circumstances, the radiating pain actually causes neck pain, which is, a little bit of a different scenario. But that's why I think, one of the most important things you can do is find someone that you trust that listens to you and listens to the symptoms you're having because you can piece it together and get a good treatment plan together with your doctor.
Wonderful. Well, thank you so much for taking the time. I know you have a lot
Yeah,
going
thanks,
on, so we
Christine.
really, really appreciate it. Again, Dr. Wilt sees patients in Egg Harbor Township as well as Manahawkin. My number and my email are in the email that you received reminding you about the talk tonight. So please reach out if you have any questions or if you'd like to schedule an appointment with Dr. Wilt.
Thanks, everybody. Thanks for
Alrighty, good
tuning in.
night. Thank you.